to share a slide presentation that I have to give in Turkey. So we'll see how that goes. So here we go. Oh, here we go. Theoretically, you're seeing this screen. Let's see what happens if I go here. You're seeing it, so it looks like we're working. So I'll go back to it and say, good morning. I'm going to presentation today on understanding weight loss after bariatric surgery. And the topics, of course, I'm going to say the MGB is a great procedure. You just have to look at the data. I'm going to talk about the MGB still, even after 20 years, is associated with widespread confusion. And there's a lot of areas we could talk about the confusion of surgeons and patients. But today we're going to talk about this new onset of fear of malnutrition after the MGB. And then we're going to use the fact that there continues to be so much confusion about the mini-gastric bypass tests that there continues to be a need to standardize, educate, and recognize MGB surgeons who are excellent in understanding and performing the operation. So confusion, a lot of surgeons still don't understand that in hundreds of articles, in fact, as far as I can tell, in every study and by every measure, equal to or more often better than any other comparable surgery. And this includes randomized controlled prospective trials. So let me say that again. In every single study, by every measure, the MGB is equal to or more often better than any comparable bariatric surgery. So it's pretty good, and I was criticized the other day because I called it the best. It's the best. Okay, let me say this as an introduction. Look, if you don't understand an operation, if you're confused about it, don't offer it. And we see widespread confusion, people putting rings on bands and short pouches, all kinds of other errors. And so what we would ask you, if you really don't understand the operation in detail, we don't think you should use it. In short, this presentation in summary can say that number one, as I said, there's widespread persistent misunderstanding of the MGB, and this has led often to complications and even death. Again, what we're emphasizing here is one particular area of confusion, malnutrition. We think that there's a need for standardization of the MGB and recognition of surgeons who are indeed knowledgeable, have taken the time to become conversant with the details of the MGB and skilled in its use. Again, standardization, education, and recognition. The best in MGB. So we invite people who have an agreement that this is needed to join the Board of Governors Review Corporation. And that's done here on this slide. So if you're watching this in a recorded mode, you can stop it here and go to the MRC Review Corporation website and sign up to join us. Also, we'll be updating on the Facebook page as well. Confusion, I'll just emphasize again, has been present for almost 20 years now, and people have said the pouch was too big, patients will not lose weight, and that was wrong. They said, some people said, well, you should have a short pouch, and that was wrong. And there are people who said you need to dissect the EG junction and the diaphragm, and that's wrong. They said MGB would be better with a ring. That's proved to be wrong. They mentioned irrational fears not supported by the data of bile reflux being a devastating complication in many MGB patients. That's wrong. They've been confused about the data on the risk of gastric cancer after Roux-en-Y surgery used in the MGB. That's wrong. And there's a big fear of malnutrition after the MGB with a flurry of articles. And we're going to kind of suggest how that the surprise finding of malnutrition after the MGB is again a demonstration of confusion by otherwise really good surgeons. So there's a new thing in town, which is, oh my goodness, after MGB lose too much weight. And this is like a big surprise. So this is just a couple of the articles. Here's one, malnutrition in 2017, severe fatal malnutrition after the MGB. And so there's a kind of a new industry of articles saying, oh my goodness, look, malnutrition after MGB, without really understanding what to do about it. Emphasize in this presentation, this shows evidence of deep misunderstanding of the MGB, a deep misunderstanding of the Roux-en-Y, which has similar risk of malnutrition, but not mentioned in these articles, and especially of the SADI or BPD, which has much worse malnutrition, which is not mentioned in these articles, to the main. But most important, it's a misunderstanding of simple statistics, mean and standard deviation of the Roux-en-Y or the MGB or the SADI or the biliopancreatic diversion. You can predict that some people are going to get malnutrition. And again, let me say this. It's really simple. If you know the mean and standard deviation, which we do, of the Roux-en-Y or the BPD or the MGB, roughly how many people will have risk of malnutrition. And nobody mentions this in these new papers because some people will lose too much because we already know that from Roux-en-Y and BPD and MGB from the mean and the standard deviation. It's really simple, but it appears that most surgeons have no idea of this fact. And we'll try and not go too deep into statistics, but explain to you what it means and what the risks are and what can be done about it. There's a lot of different choices. On the other hand, because of the mean and standard deviation, we can say that for the band and the sleeve, it almost never happens because they're relatively weak operations. And we won't go into too much detail there, but if you have an interest, we have all the data on that as well. So here's an example of one of these fearful malnutrition studies. They had 12 people who had TPN. 7 had the one anastomosis bypass or mini bypass. And here's the quote. This case series suggests that OAGB or mini-gastric bypass could overexpose subject to severe nutrition complications. And this is in the journal of parental nutrition. And so what we'd like to say is, let's start off number 1. All of these studies seem to have ignorance of the large-scale MGB series studies. I'm only going to give 2 examples because the presentation is already over 93 slides, and we could go through dozens here, but here's 2 examples, and basically all large-scale MGB series are the same. So let me say this again. All large-scale MGB series are the same. Malnutrition after MGB. The risk is low and the treatment is easy if the surgeon knows what to do. So I'll say it one more time. There are now dozens and dozens of large-scale, thousands of patients followed for long periods of time, including controlled prospective randomized trials, and the answer is always the same. The risk of malnutrition is low and the treatment is easy. And with some statistics, you can see that was obvious before these kind of new arrivals began identifying a few cases of malnutrition. Study from 2016 in Taiwan, they had 49 people out of 2,300 cases who had conversion for malnutrition. That's about 2%. And 58% of the conversions for malnutrition, so that's 1% of MGBs, had revision for malnutrition. Here's a study by Chevalier, also 2005, bypass long-term results, malnutrition requiring revision 1.6%. So, MGB studies show malnutrition rates causing revision are low. And again, I could go over dozens. My own practice is about 1%. But what about the Roux-en-Y? In other words, all these things are, oh my goodness. Well, again, this shows pretty severe misunderstanding because the Roux-en-Y has malnutrition revision rates roughly equal to the MGB, maybe slightly lower, maybe slightly more. It depends on the study, but Here's just a simple example you can find out in 30 seconds. If you search Pubmed, the National Library of Medicine in the United States, for Roux-en-Y gastric bypass, you'll find references to about 11,000 articles. If you search Roux-en-Y gastric bypass and malnutrition, you'll find 480 articles. That's about 4% of all the articles on Roux-en-Y are about malnutrition. And if you search deficiency, another kind of issue, there's about 514 articles, or about 4%. And here's just some samples. Remember, there are 480 of these. I just picked out a few recent ones. Revision surgery for severe protein-calorie malnutrition after Roux-en-Y, 2016. Endoscopic reversal gastric bypass for severe malnutrition after Roux-en-Y, 2015. Risk of malnutrition, trace metal and vitamin deficiency post Roux-en-Y, 2015. Malnutrition myopathy following Roux-en-Y, 2001. And there are 400 more articles. Roux-en-Y bad, it means that the people writing these and other articles often misunderstand statistics. And we'll try and explain these things to you later. Here's a study which I thought was interesting. The Department of Surgery at the University of Virginia said, I wonder how many of our Roux-en-Y patients had feeding tubes. In other words, that's not routine after weight loss surgery. And in 2016, they found almost 4% of their patients ended up with a feeding tube. That's not good. And there's more to it than that, but hello, 4% had such severe malnutrition or other problems, they had to be fed by a tube. 4 out of 100 of every 100 patients. Not good. Again, not to be critical, but that's not good. There's nowhere in any of the medical literature that MGB patients have to have feeding tubes at a rate of 4 per 100. In 2017, the new incoming IFSO president, Dr. Himpens, published a paper on Roux-en-Y side effects, and malnutrition was one of the important causes of Roux-en-Y revision. Here's a systematic review article, 35 articles. Malnutrition was the most common indication for reversal, followed by dumping syndrome, hypoglycemia, and excess weight loss. This is 2016. Here's a Journal of Parenteral and Enteral Nutrition article. 54 patients had TPN that they found in their series after bariatric surgery, and the most common procedure was Roux-en-Y, 72%. And malnutrition was the common indication for TPN. And just another study comparing the drop in albumin protein in Roux-en-Y found the sleeve was actually a little bit worse. But again, because of statistics, because the sleeve is so weak, malnutrition is a lot less common. And again, if you understand the statistics, you'd understand that statement. And we'll try and go through that in a short summary later. Here's another study on excessive weight loss. And this is the thing I was interested in here. These patients after Roux-en-Y in 2016, some had BMI of 14. That's malnutrition. That's Roux-en-Y. The other thing that I think is interesting in these papers about malnutrition in the MGB, they neglect their papers. And so SADI is a new variation of BPD, but in one recent paper published in 2017, 1 out of 3 patients had malnutrition. So let's look at this. This is from Obesity Surgery 2017, so you can look it up. They reviewed 12 studies, including 581 SADI patients, and the percent excess weight loss was 85% at 2 years. And again, if you know statistics, you know a high rate of malnutrition if your mean is 85% excess weight loss and your standard deviation is around 25%. We'll talk about these things later, but hello, 1 person out of 3 with malnutrition. That's not good. But most important, we're going to talk about is simple statistics can allow the reader, the surgeon, and the patient to understand the risk of malnutrition. And we're going to talk about with the MGB, and then we're going to talk about the fact that the MGB is unique in this area because it can be tailored and wishes and needs of the patient and desires of the surgeon. Now, this is complicated, and I hope you'll forgive me, but what we're going to show here is if we use a little bit of statistics, and I've summarized this. I have a further presentation which has 93 slides where I go through it in detail, but I didn't think anybody would listen. Not that you shouldn't, but I don't think you would. But if you say, let's just make up some numbers, these are from a review of about 20 studies of each of these operations. The mean percent excess weight loss for Roux-en-Y, MGB, and biliopancreatic diversion, roughly 68, 72, 80 is the rough number. Variations. So the Roux-en-Y is pretty good. MGB is a little more powerful, and the SADI is very powerful. Now, the other thing that I have studied, which is really easy to look up, is the standard deviation. And standard deviation, just to remind you, is the spread of the distribution of the events around a mean. And interestingly, the standard deviation, or the accuracy, the precision of each of these operations is about the same, which is they're not very precise. The standard deviation plus or minus the mean is around 20, 25%. We assume that if you lost every bit of your excess weight loss plus 20% more of your excess weight loss, probably that's a pretty good indication you've lost too much. So we're going to define that for the purpose of trying to explain this to the listener. That if you lose 120% of your excess weight loss, that probably you're at risk. Okay. If you take all those things together, and let me summarize them again: Roux-en-Y, MGB, BPD, SADI, that they're roughly excess weight loss is around 68 to 80%, and the standard deviation for each one's around 20 to 25%. All these are correct. I won't go into detail for you. And then if we just make up a number, say 120% is probably going to lead to malnutrition or indication of malnutrition. Then we can easily predict the expected rates of malnutrition. And this is simple statistics for each one of these. And I'll go through that. It's a little complicated, but stay with me because there's a big teaching point here. So here's the Roux-en-Y, and if we say that it has around 72, 68%, it's a low risk of malnutrition. In this case, it comes out 1.8%. If they have less power, which some studies do, then it would have a less rate, but let's just say low. So Roux-en-Y has a low risk of having malnutrition, which we define for the purposes of the study of losing more than 120% of your body weight. So that of all the people who have the Roux-en-Y with these statistics, about 1 to 2% will lose more than 120%. This is statistics. And I'm not going to go into more detail. If you don't understand this, maybe go back and do a little bit more reading. But it's really simple. What we're saying is really simple. If you know the mean excess weight loss, and you can predict the risk of malnutrition. Now let's do that for the MGB. If we say, in this case, 78%, then the risk will go up to almost 3%. But remember, we're going to talk about the MGB can be tailored. And again, if we look at the BPD and we made up a number of, say, 82%, which is pretty close, same standard deviation, 24%, risk of malnutrition would jump to 6%. And so all of a sudden, based on that mean and standard deviation, you can predict malnutrition. Now, this is very important. So let's go back to the recent papers about malnutrition saying, we have discovered malnutrition in the MGB. No. What they have done is misunderstood the obvious. The BPD and a similar operation with similar power, the MGB, will have a rate of malnutrition because of statistics. It's simple. I could explain it more, but I'll hold off. Because I'd like to talk about my study, which says something also really simple. Surgeons not agree with this simple statement. And we'll talk about some statistics and a type 2 error. But basically, I'm going to say something really simple, which is a longer bypass means more weight loss. And there have been recent surgeons saying that's not true. And they're wrong. And I'll show you my statistics. So I'm going to say this again. Longer bypass means more weight loss. That's not true. And there are studies showing it's not true. They're wrong. And the statistical error they made is what's called a type 2 error. But let me show you the true and correct data. This is the linear regression model for my survey of about 4,000 patients. It was a survey of their outcomes, and we compared that. And if you do it in 3 dimensions, you can see that those who started off at a higher weight lose more weight. Limb length, as it goes up, weight loss goes up. But if you go back to this, you see nice lines, but that's untrue because that's the mean. And many people don't think beyond the mean. These are the individual cases from one of the runs on the database. Is that the data, the actual truth of the patients are all over the map. Okay? So when you see a line or a mean, that's summarized all this variation, and the standard deviation tells us about the variation. But what we can tell you is this is the largest series on bypass limb length. Those studies that showed no effect of bypass limb length on weight have what's called a type 2 error, which in summary means if you have a small sample size, you might not be able to find a difference, and you might conclude there is no difference when there really is. And so our study, very large, shows it is. And so the demonstration, our studies show something similar, which is if every time you add a bowel to the bypass, there's the expected and predicted weight loss. Okay? So let's say this again, because people disagree with this and they're wrong. I mean, I apologize for criticizing anybody. I don't mean to criticize them, but it's just obviously wrong. And there are papers that say this wrong, and people say it and it's wrong. So let's say it what's right, which is longer bypass means more weight loss. Means more weight loss. Longer bypass means more weight loss, which you can say that another way, which is longer bypass means more power. But here's the third most important point. If you choose more power, remember those statistical graphs I showed you, longer bypass, more power means you will increase the risk of excess weight loss, and you can calculate that prediction. Okay, but the MGB is unique. The MGB is unique. The MGB is unique because it offers the surgeon and the family a choice to choose more power or greater or less safety as far as risk of malnutrition and other. The surgeon, the family, the patient can choose an operation that more clearly matches their situation, and the Roux-en-Y and the BPD do not offer this. So let's imagine that we could classify the MGB in 2 relatively effects and look at the outcomes. So the biliopancreatic limb length of 200 centimeters means that you have an increased risk of excess weight loss or malnutrition on the range of 1 per 100 patients. Okay? On the other hand, if you choose a conservative biliopancreatic limb length of about 150 centimeters, the risk of excess weight loss goes down to 1 in 1,000. And we see that in my data and others. And what it means is that if you choose the more conservative biliopancreatic limb length, the mean excess weight loss will go down, and the chances of reaching your ideal body weight go down. Trade-off, which you can use this knowledge. So here's an example. Imagine a 50-year-old diabetic. Glucose is high, insulin levels are sky high. The patient is already blind in one eye and losing sight in the other. So he faces incipient blindness from the severe persistent hyperglycemia. Gangrene is present on 2 toes, and he faces, he's had 1 or 2 myocardial infarctions, a stroke, a recent TIA, and to add to the fear of the family and to you, a physician, cardiologist, specialist friend calls you and says he predicts with strong feelings on his part will die in the coming year. And now you discuss the options of treatment with the family. You could, you don't have to, but it is your option. You could choose a biliopancreatic limb length of 200 centimeters. This gives the patient a better chance, a more powerful operation, a better chance of reaching their ideal body weight and resolving the associated comorbidities. Power of the dose of bariatric surgery is increased. So there is a risk of excess weight loss and malnutrition of about 1%, and you have to balance that. And in the situation of the mini gastric bypass, you have the option to balance that. Conversely, maybe you're seeing a young female, BMI is 40 or lower, possible poor follow-up issues. Maybe she's a vegetarian. You might choose a conservative limb length of 150 centimeters. Excess weight loss is low at 1 in 1,000 cases, but can still happen. And the chances, though, of having the BMI 40 go back to normal decline because you're choosing a weaker, although safer, biliopancreatic limb length. So modulating the risk of malnutrition and excess weight loss, the study demonstrates the power and risk relationship. The MGB is unique in allowing the patient, the surgeon, to titrate operative choices based on preferences, and secondarily, to easily address post-op excess weight loss or malnutrition.